Hello friends, today I am going to talk about a topic which is very important but we always take it for granted. And what is that? It is the maintenance of balance. How is it important? We realize the importance of maintenance of balance only when we encounter a disorder of balance. Even if it is a seemingly benign condition like BPPV, it can be very alarming. The patient may even refuse to get up from his bed because of the severity of the disorder. So the topic for discussion for today is physiology of equilibrium. We have already learned about the physiology of hearing, and today we will be discussing about the other function of inner ear, that is in maintenance of equilibrium. Equilibrium is being maintained by interplay of three things. Now what are these three things? First of all, I will show you this experiment which you have been doing from your first year onwards. What is this clinical test which you do? We ask the person to close his eyes while standing up like this, and we will be looking if he is losing his balance or not. And this is what is called the Romberg's test, isn't it? This Romberg's test you have been doing from our first year onwards, right? Now this Romberg's test is very important because it helps you realize if one of the three has been cut off or not, because the three things which are needed for maintenance of balance are the vision, the proprioception, and from the inner ear you need the maintenance of equilibrium. For that you need signals coming from the both the semicircular canals as well as utricle and saccule. I already told you the semicircular canals deals with the angular acceleration and the utricle and saccule deals with linear acceleration, right? So the signals coming from that will be needed. Then the proprioceptive signals from the foot will be needed. Then the vision is also needed. That is why when you are closing the eyes, this is getting cut off, right? The vision is getting cut off. So only proprioception and inner ear signals remain. So if he is having a problem with proprioception, for example in a diabetic neuropathy, if he is unable to feel his own feet, then he will have Romberg's test positive. If there is any problem with the inner ear in a severe vestibular neuronitis or labyrinthitis, then also he will be having problem with maintenance of balance, right? So these three things are needed for the maintenance of balance. And how is this balance being maintained? If you look carefully in this catch being taken by Sanju Samson, he is fixing his eyes on the ball even while he is running and diving to take that catch. How is he able to fix his vision on the ball and not get the vision blurred? How is the vision sharp enough even while he is running? This is because of two reflexes that are taking place. And what are they? They are the vestibulo-ocular and the vestibulo-spinal reflex. The vestibulo-ocular reflex help him maintain his vision on the ball, and the vestibulo-spinal reflex along with the vestibulo-colic reflex helps his spine posture maintained. Okay, the spine posture has to be maintained even while he is diving so that the balance is maintained, right? So that requires the vestibulo-spinal reflex. Okay, so these two reflexes are which are helping him maintain the balance. These things are happening in an unconscious manner. The patient is not at all conscious of what is happening, how the balance is getting maintained. We are all not at all aware of how our balance is maintained. Even while I sit and take this class, there is a balance happening. Okay, the spine has to be maintained straight, and when I am looking straight into the camera, then while I look to the slides, there should be no blurring. All these are being maintained because of the vestibulo-ocular and the vestibular-spinal reflex. Now to the details of how these vestibulo-ocular and vestibulo-spinal reflex. First of all, let's see the picture which you are familiar with in the anatomy of inner ear. Here you can see the inner ear, the part of inner ear which is seen within the bony labyrinth. What is that? It is a membranous labyrinth, and this membranous labyrinth consists of the three semicircular canals. Okay, Now which is this? This is the posterior semicircular canal, since it is going posteriorly like this. This is the lateral semicircular canal, and this is the superior semicircular canal, right? Now the posterior and the superior join together to form the crus communi, or the common crus, right? All these things we are learned. Now which ear is this? This will be the right ear, because this is the posterior part, this is the anterior part, okay, anterior of the superior semicircular canal. Now all these are opening into the utricle, and from the utricle you have the saccule, and from the saccule through the ductus reunions it is connected to the cochlea, right? This is the ductus reunions. Okay, so in these semicircular canals you have a specific set of receptors, and in the utricle and saccule you have another type of receptors. Now what are they? What are the receptors seen in them? Yes, in the semicircular canals you have the ambula, or the crista ambularis. Crista for canal, right? And it is seen in the ambulated ends, the widened ends of the semicircular canals. Okay, you have the crista ambularis, which are the sensory epithelium for maintenance of rotational acceleration or angular acceleration. Okay, angular acceleration is being maintained by the crista ambularis, and linear acceleration is being maintained by the utricle and the saccule. Okay, utricle and the saccule maintain the linear acceleration. Now coming to how the angular acceleration is being maintained, as you can see, the semicircular canals, they are arranged in this manner. That is, the horizontal semicircular canal is not exactly horizontal. The plane of horizontal semicircular canal is about 30 degrees above the naso-occipital plane. Okay, above the naso-occipital plane you have the plane of horizontal semicircular canal and utricle at an angulation of 30 degrees. Okay, and then you have the anterior or the superior semicircular canal and the posterior semicircular canal arranged in 90 degrees to each other. Okay, all these are 90 degrees to each other, and the angle between them is what is called the solid angle, right? And these semicircular canals act in pairs. Okay, how the left anterior semicircular canal and the right posterior semicircular canal form a pair, and the left posterior and the right anterior, they together form another pair. Okay, so these pairs along with the pair formed by the right and left horizontal semicircular canal helps in maintenance of balance. Now how is it being done? For that you have to know there is something called inertia, right? When you are moving in a bus, if suddenly it stops, we still keeps on moving, right? So such an inertia is taking place even in the semicircular canals as well. How is it happening? When the semicircular canal moves along with the movement of the head, the endolymph within the semicircular canal moves in the opposite direction due to the inertia, and because of this movement of the endolymph in the opposite direction, it moves the, what is this thing, this gelatinous structures within the ambula. What is that thing called as? It is called the cupula. Cupula is the thing which is seen within the ambula of the semicircular canals. Okay, within the ambula of the semicircular canals you have the cupula, which is a gelatinous structure, and it projects upward like this, and within it you have the hair cells. Okay, what are the hair cells you have? You have the type 1 and the type 2 hair cell, right? Type 1 is goblet shaped and the type 2 is cylindrical in shape. Type 1 has got calyxial nerve endings, which are the afferent nerve endings, and in the type 2 you have the Boughton type of efferent nerve endings, right? Okay, so these hair cells are arranged in the ascending order, similar to you standing in an assembly, and because of the movement of the endolymph, these hair cells also move. Okay, and the stereocilia move towards the gynoecilia, and this movement of stereocilia towards gynoecilia stimulates. Okay, it causes stimulation, and the movement of stereocilia away from the gynoecilia causes inhibition. Okay, and that is how the signals are being generated. Okay, when the movement of stereocilia is towards the gynoecilia, that generates signals, and these signals are being conveyed by the vestibular nerves. Now, what is the innervation of the semicircular canals? The semicircular canals and the utricle is being stimulated by the superior vestibular nerve, except for the posterior semicircular canal. Okay, the posterior semicircular canal is being innervated by the branch of inferior vestibular nerve, and what is that? It's called the singular nerve, and that is the single most common cause of vertigo, the posterior semicircular canal, BPPV. Easy to remember that thing, right? And the singular nerve is being cut in singular neurectomy for recalcitrant BPPV, and this singular neurectomy is also known as Gessex procedure. Okay, these are the things that you have already learned, right? I'm repeating it again and again so you remember this. Okay, now how are the hair cells arranged? In the lateral semicircular canal, the utricupetal flow of endolymph, that is towards the utricle, will cause stimulation. Why? Because here the gynoecilia is seen towards the utricle or towards the ambula, whereas in the vertical semicircular canals, that is the posterior and superior semicircular canal, these gynoecilia are seen away from the utricle or the ambula. So, movement of the cilia towards the gynoecilia will result in stimulation, and it is the utriculopetal flow of endolymph that causes stimulation in the case of the lateral semicircular canal, and in the case of posterior and the anterior semicircular canal, it is the utriculofugal movement that is causing the stimulation. Okay. So, when the hair cells are moving with the movement of the endolymph, the stereocilia, if it moves towards the gynoecilia, it results in stimulation or depolarization. If it moves away from the gynoecilia, it results in inhibition or hyperpolarization. Okay, and how is this happening? This is happening because the tipplings are getting stretched when the stereocilia moves towards gynoecilia, and the stretch activated ion channels are opening, and that is resulting in ion influx, that is the potassium as well as the calcium influx is occurring, and because of that there is depolarization and upward movement of the insertional plane or the plane. Okay, so this is what is resulting in depolarization and hyperpolarization. Now, how are these semicircular canals arranged? I told you they are arranged in pairs, right? The left anterior semicircular canal is arranged in synergy with the right posterior semicircular canal, and the right anterior semicircular canal is with the left posterior semicircular canal, and both the horizontal semicircular canal, they form a synergistic pair. Okay, and this arrangement is actually causing a push-pull mechanism. That is, when you are moving towards the right like this in the horizontal plane, then the right horizontal semicircular canal is activated and the left horizontal semicircular canal is inhibited, right? And if you are moving like this, the left horizontal semicircular canal is activated and the right is inhibited. Okay, and similarly, when you are flexing your head and moving towards the right like this, then it is in the plane of the right anterior semicircular canal, right? So the right anterior semicircular canal is activated by the left posterior semicircular canal, which forms its pair. It is getting inhibited, and if you are going like this, if you are extending your head upwards and in the right direction, then it is the right posterior semicircular canal that is activated and the left anterior semicircular canal that is inhibited. And when you are moving your head towards the left like this anteriorly and flexing your head, then it is the left anterior semicircular canal that is activated and the left right posterior semicircular canal that is inhibited. And if you are moving upwards and extending the head like this, then it is the left posterior semicircular canal that is activated and the right right anterior semicircular canal is inhibited. So they are acting in pairs. Okay, pairs. So how is the signal getting conveyed? How are the reflexes being maintained? I already told you the semicircular canals, the horizontal semicircular canal and the superior semicircular canal or the anterior semicircular canal, they are being innervated by the superior vestibular nerve, right? So they are being innervated by the superior vestibular nerve along with the part of the utricle. Okay, along with utricle, which is getting innervated by the superior vestibular nerve, and the inferior vestibular nerve is innervating the posterior semicircular canal through its singular nerve, okay, which is a branch of the inferior vestibular nerve, and also it is innervating the saccule. Okay, now superior and inferior vestibular nerve, they join together to form the vestibular nerve, and what happens to it? It goes into the ganglion, and what is that called? It is called the Scarpa's ganglion. Okay, it is the Scarpa's ganglion, and from the Scarpa's ganglion it goes into the internal auditory meatus, and through that it reaches the brainstem. Okay, through the internal auditory meatus it reaches the brainstem, and within the brainstem there are vestibular nuclei. Okay, vestibular nuclei. Okay, and within the brainstem you have the vestibular nuclei, and it is from the vestibular nuclei through the medial longitudinal fasciculus the signals are going into the exterocellular muscles as well as the spinal muscles. Spinal muscles are needed for the writing reflexes and for the maintenance of posture via the vestibular spinal reflex, and the exterocellular muscles are being innervated so as to maintain the vision in one particular direction. Okay, that is through the vestibular ocular reflex. Okay, so this results in the vestibular spinal reflex, and here you have the vestibular ocular reflex. Okay, so these two reflexes are helping you maintain the vision as well as balance. Okay, now there are certain laws pertaining to this. What are they? They are the Evol's law. The first Evol's law say that the head and the eye movements always occur in the plane of the canal being stimulated and in the direction of the endolymph flow. So when you are moving towards right like this, it is the right horizontal semicircular canal that is getting stimulated. Okay, and yes, the second law states that in the left, in the lateral semicircular canal, ambulopedal endolymph flow causes a greater response than the ambulofugal flow. Okay, so in the horizontal semicircular canal, it is the ambulopedal flow which is causing a greater response, or rather ambulopedal flow is stimulatory. And why is that happening? I already told you. In the lateral semicircular canal, the stereocilia is seen away from the utricle or the ambula. It is the kinocilia which is seen nearer to the ambula. Okay, kinocilia is seen nearer to the ambula, and so the stereocilia will have to move towards the kinocilia, okay, to cause excitation. Whereas when the stereocilia is moving towards the kinocilia, in the ambulofugal movement, in case of posterior as well as superior, not just posterior, it is both posterior and superior semicircular canal. Okay, okay. In the vertical semicircular canals, what is happening? It is the ambulofugal endolymph flow. Why? Because here in the vertical semicircular canal, the kinocilia is seen away from the ambula. Okay, you have this is the kinocilia, and here you have the stereocilia. Okay, the stereocilia are seen towards the ambula and the kinocilia is seen away from the ambula. So when the stereocilia moves towards the kinocilia, that is away from the ambula or away from the cupula, when it is moving, it is causing the excitation. So the ambulofugal flow or the utriculofugal flow is what is causing the stimulation. Okay, the stimulation is being caused by the ambulofugal flow. Okay, so that is the basis of the Eval's law. Okay, Eval's law. Now, on the basis of this, there is a test that you do. What is that? It is called head thrust test. Okay, what is being done in head thrust test? We are asking the patient to fixate the vision over an object. For example, you can ask them to look at your own nose. Okay, and we just move the head of the patient, and then we will look for the patient's vision if it is still fixated on the nose or not. The first instance, which is a normal head thrust test. Okay, and the head impulse test is negative. What is happening here? The patient's vision is still fixated on your eyes, on your nose. That is why the eyeballs are towards the right here. Okay, even when the head has moved towards the left, the eyeballs are in the right. Okay, that is because of the vestibular ocular reflex pathway is happening normally. Okay, only if it is normal this can happen. Okay, now if it is abnormal, what happens is that there will be a lag for some time. Okay, the patient will be looking in the direction where the head is moving for a brief period, and only then it comes back to this direction, that is to the nose where his or her vision was fixated upon. Okay, this is what is called a positive head impulse test. Okay, positive head impulse test means there will be a lag. You will be able to see that the eyes are going to the left, and then suddenly it comes back to your nose. Okay, so this is a positive head impulse test, and this is used for assessing the vestibular ocular reflex that we saw now. Okay, so there is something called nystagmus, right? It is the involuntary eye movements. It is the involuntary rhythmic eye movements which occur because of the vestibular ocular reflex having some problem. Okay, that is, sometimes there will be increased excitation from one vestibular system. For example, if there is an irritative lesion in the labyrinth, if there is a labyrinthitis on one side, from there the signals will be more, right? And because of that, there will be excitation, and that excitation will be causing the eye movements to that side, because the movement of the nystagmus is considered with its fast movements. Fast movement is actually the compensatory movement. Okay, slow movement is the direction in which the eyes move because of the irritation, because the vestibular system on one side pushes the eyeballs towards the opposite direction. Okay, the vestibular system of one side pushes the eyeball towards the opposite direction, and when it is irritative, what happens is it is getting further move towards the opposite direction. So in a irritative lesion of the labyrinth, there will be a counter current movement towards the same side, and that counter current movement is the corrective saccade. Okay, that corrective saccade is what we appreciate as the nystagmus. Okay, it is the fast movement we appreciate as the nystagmus. Okay, we will be going more into the nystagmus on the next class. For now, just for understanding, okay, why this is occurring. Okay, why this kind of thing is occurring, and the fast component of the nystagmus will be always opposite to the direction of the flow of the endolymph. Okay, the fast component of nystagmus will be always opposite to the direction of the flow of endolymph. And yes, you can assess the vestibulospinal reflex as well. How? This is being done by a test known as Underberger's test. Okay, Underberger's test, how we are asking the patient to jog by keeping the hands like this. Okay, not jog, to march on the same spot, and if he is moving towards one direction, that is indicative of a vestibular lesion on that side. Okay, this is also known as Fukuda's test. Okay, Fukuda's high stepping test. So Underberger's test or Fukuda's high stepping test is for vestibulospinal pathway. Okay, whereas the other one, what is that? The head thrust test or the head impulse test is for vestibulo-ocular pathway. Okay, vestibulo-ocular pathway. Now you have now learned how the vestibulo-ocular reflex and vestibulo-spinal reflex are very important, right? And these reflexes are being maintained by the angular acceleration which is being caused by the semicircular canals. Okay, the semicircular canals are detecting the angular acceleration and maintaining the vestibulo-ocular as well as the vestibulo-spinal reflex. Okay, and this is because of the movement of endolymph due to the inertia when you are moving the head, and this inertia and the movement of endolymph results in the stimulation of the semicircular canals by stimulation of their receptors. And what are the receptors of the semicircular canals? C4C, and that is crista ambularis, which is located in the ambular part of the semicircular canal, that is the widened part. It has got the crista ambularis, where you can see the cerebellum and the kinocilia. All of these are tufted together in a gelatinous structure called cupula. Okay, so that is how it happens. Now what happens if the autoconia which are seen in the utricle and the saccule, if it get dislodged due to some reason and goes into the semicircular canals? We know that the three semicircular canals, they open into the, all of these open into the utricle, right? And then you also have the saccule here. Okay, now what happens if the stones go into this? This is the most common area because this posterior semicircular canal lies below the utricle. Okay, the direction is below the utricle, so it is more easier for it to go into the posterior semicircular canal. So if this autoconial debris, where are these autoconial debris seen? They are seen in the macula, which is the receptor of the utricle and saccule. And from the macula, if these autoconal debris get dislodged for some reason and go into the semicircular canals, okay, it can go either into the canals, okay, then it is known as canalolithiasis, or it can go into the ambula where you have the utricle, where you have the cupula. Within the ambula you have the cupula, right? Cupula is a gelatinous structure, right? If it goes into that and sticks in there, it causes cupular lithiasis. And this canalolithiasis and cupular lithiasis are the basis for BPPV. Why? Because usually it has been due to the movement of the endolymph with the movement that is causing the excitation or inhibition. But now what is happening when you are having something which is heavy, which is having a specific gravity greater than that of the endolymph, and going into the canal and sticking into the cupula, what happens is that that particular canal becomes gravitational dependent. And so when you are putting the patient in that position, for example, when you are putting the patient in a plane of the posterior semicircular canal, as you can see here in the disc salpike test that is being done, then what happens is that that posterior semicircular canal is getting activated, and that is resulting in the nystagmus and the vertigo sensation. Okay, so this is the basis of BPPV, and this actually explains why the semicircular canals do have a particular role in maintenance of the balance. Okay, the patient comes to you saying that he is having certain severe vertigo when he is moving in a particular direction only, otherwise he is not having vertigo, and that is getting relieved after a few seconds. Okay, it will take 30 to 45 seconds that severity of vertigo to come down. Okay, so that is a typical presentation of BPPV, and here what is happening, the semicircular canals are having the otolith which is to be seen within the utricle. Okay, and this is causing the BPPV. Now what is the function of this utricle and saccule? Now you have seen that this utricle and saccule have these stones which come to the semicircular canal, and that is causing all the problem. BPPV is the most common cause of vertigo, right? and even though it is a benign condition, it is very debilitating to the patient. Okay, so why all these things have to occur? Why in the first place you need an otolith within the utricle and saccule? This you can know if you see this video where the CEO of BMW falls down suddenly. Okay, now why is he falling down? He is falling down due to a Tumarkin's crisis. Tumarkin's crisis. Okay, now where do you see this Tumarkin's crisis? It is seen in Meniere's disease. Okay, what is Meniere's disease? It is the endolymphatic hydrops which occurs in a primary manner. And this endolymphatic hydrops, when it occurs, what happens is that there will be fluid within the saccule. Okay, saccule is distended with fluid, and because of that the patient is unable to maintain the balance while standing itself. I told you while going up and down in a lift, it is the saccule which maintains the balance, and while moving forward it is the utricle which helps to maintain the balance. So the linear acceleration is the function of the utricle and saccule, and in that the up and down movement is by the saccule. Okay, up and down you have the saccule, and forward and backward you have the utricle. Okay, so this is how the linear acceleration is being maintained. Here also what is happening is that the cerebrocelia is moving towards the gynocoelia, but instead of the endolymph which is flowing, it is the otoconal debris above this cilia that is getting a shearing action from these cilia. Okay, that is what is causing the stimulation of utricle, okay, or saccule. So that's about the utricle and saccule and how they maintain the linear acceleration, how it is important. And of course it has got the type 1 and type 2 hair cells, as you can see here. Type 1 and type 2 hair cells are very important for conveying the nerve impulses. Okay, I told you it is due to the movement of cerebrocelia towards gynocoelia where the tiplings get stretched, and the stretch activated potassium and calcium channels are getting activated, and that is resulting in release of the nerve impulses. Okay, the neurotransmitters are getting released. Okay, now what is the function of these utricle and saccule? Along with the horizontal semicircular canal which maintain the angular acceleration, you need utricle and saccule to maintain the linear acceleration that I already told you. Okay, but how is it being maintained? Similar to the semicircular canals which maintain the vestibular ocular reflex and the vestibular spinal reflex, here also you need contribution from the utricle and saccule. Okay, utricle is being stimulated by being supplied by the superior vestibular nerve, right, and it goes into the internal auditory meatus, right, after becoming the vestibular nerve. It goes through the internal auditory meatus, and here you have the vestibular nuclei, right, and through these vestibular nuclei, it from the utricle what happens is it goes into the contralateral extraocular muscles are stimulated so as to relax it, whereas in the saccule what is happening is it is going into the ipsilateral sternocleidomastoid. Okay, ipsilateral sternocleidomastoid gets relaxed. Here it is the contralateral extraocular muscles that are getting relaxed. Okay, so this is happening with loud sounds. And how are you measuring it? It is with the help of WEMP. There are two types of WEMP, C-WEMP and the O-WEMP. Okay, here you can see the C-WEMP and here you have the O-WEMP. Okay, in C-WEMP the electrodes are kept in the sternocleidomastoid area. In the O-WEMP it is seen around the eyes. Okay, so as to get the impulses from the extraocular muscles. Okay, So how is it getting conveyed? From the utricle you can see it is going into the 8th nucleus, and through the medial utricle fasciculus it is going into the 3rd nucleus. Okay, you know, this is how the vestibular ocular reflex is being maintained, right? And for that you do a head impulse test to assess, right? And in addition to that you can do an OM to assess the utricle and the superior vestibular nerve function. Okay, now this is going into the opposite extraocular muscle through the 3rd cranial nucleus, and this is causing its relaxation. Similarly, the saccule is innervating the same side. You can see here from the 8th nucleus it has gone to the opposite side through the MLF. Okay, so the OM, it is the opposite direction, O for O. Opposite nuclei is getting stimulated, whereas in CM it is the same nuclei, same side nuclei is getting stimulated. Okay, sorry, it is getting inhibited actually, it is causing relaxation. OM is also causing relaxation. Okay, so the difference is that OM, it is in the opposite eye and it is the extraocular muscles that are getting innervated. Here it is the sternocleidomastoid or mastoid muscle. Okay, so because of that we will be able to know the presence of normal sebum is indicative of normal saccular or inferior vestibular nerve, and presence of normal OM is indicative of normal utricle or superior vestibular nerve. Okay, so in this way, if you are getting a normal sebum and normal OM while you are investigating a patient, you can know if it is a patient having a normal saccular or inferior vestibular nerve or a normal utricle or superior vestibular nerve. Okay, so we have learned today how equilibrium is being maintained with the help of the vestibular system and along with the signals coming from proprioception and vision. And this is the basis of the Romber's test which we have been learning from our first year days. And here what we are looking for is if either of these three is getting dysfunctional. When you are closing the eyes, the patient will fall down because of the loss of balance. Okay, that is what we are assessing for in the Romber's test. And this vestibular system consists of the 3 semicircular canals as well as the 2 otolithic organs. And these 3 semicircular canals, with the help of the crista ambularis seen in the ambula. Okay, these are the receptors for rotational acceleration, and they maintain the rotational or the angular acceleration. Okay, rotational acceleration or the angular acceleration is being maintained by these 3 semicircular canals, and it is with the help of crista ambularis, not the innova crista, it is the crista ambularis which are seen on the ambula of these semicircular canals. They are able to maintain the rotational acceleration. And you have the 2 otolithic organs which have the macula, and they help in maintaining the linear acceleration, right? Linear acceleration. So the crista ambularis is for rotational acceleration and the macula is for linear acceleration. Now how is this rotational acceleration being maintained? And this is being done by the help of semicircular canals moving in pairs, right? That is the 2 lateral semicircular canals, the right anterior and the left posterior, and the left anterior and the right posterior. These pairs help in maintenance of the equilibrium. Okay, these semicircular canals which act in pairs help in maintenance of the equilibrium. How? When you are moving the head flexed towards the right, then it is the right anterior semicircular canal which is getting stimulated, and at the same time the left posterior is getting inhibited. Okay, when you are looking right with the head extended, it is the right posterior it is getting stimulated and the left anterior is getting inhibited. Okay, so in that manner they do activate the semicircular canals are activated in this manner so that the signals go as a push-pull mechanism. That is, on one side there is stimulation, on the other side it is inhibition. How is this stimulation happening? It is because of the flow of endolymph in the opposite direction due to the inertia, and this movement is causing the movement of the stereocilia towards the kinocilia. Okay, when the stereocilia move towards the kinocilia, it results in the stimulation. And where are these kinocilia located? These kinocilia, they are seen in the area of the utricle. Okay, they are seen in the utricle, and this utricle are towards the area of the ambula, right? And so these kinocilia move because it is seen towards the utricle in the case of lateral semicircular canal alone. Okay, in the case of posterior as well as anterior semicircular canal, so the vertical canals, you have it away from the utricle. Okay, away from the utricle, and this is the reason why the stereocilia movement towards the kinocilia is seen as a utriculopetal movement. Okay, this is a utriculopetal movement. Okay, in case of, this is a utriculopetal movement in case of lateral semicircular canal, whereas in case of posterior and anterior semicircular canal, it is a utriculofugal movement. Okay, utriculofugal movement, and this is what the Ewald's law states. Okay, Ewald's law states that the ambulopetal movement is stimulatory in case of the lateral semicircular canals, whereas in the case of the vertical canals it is the ambulofugal movement which is stimulatory. And of course the movement occurs in the plane of the semicircular canals, which is the first Ewald's law. So there are 3 Ewald's laws. Okay, so that's about the physiology of equilibrium. Now you will be learning about vertigo, which occurs when there is any problem with the maintenance of equilibrium, and the types of vertigo such as central and peripheral vertigo, and various disorders associated with vertigo. In the next class we will be learning about the evaluation of a case of vertigo, how to look for the different causes of the vertigo by doing certain tests. All these things you will be learning in the next class. For now, goodbye.